Everyone. Thank you for taking time to join us for this webinar. My name is Janet Heischetter and I serve as the Executive Director for the Dystonia Medical Research Foundation, and it's my pleasure to moderate this program. You might be asking, why is the Dystonia Medical Research Foundation doing a program on cerebral palsy and dystonia? And I think that's probably a fair question. The simple answer is that many people with cerebral palsy also have to deal with the issues and the challenges of dystonia. Like people with Parkinson's disease or Wilson's disease also may develop dystonia. So tonight we're going to learn more about cerebral palsy and dystonia, and I'll just get smarter because of our wonderful speakers. So we're looking forward to it. Before that, though, just a couple of announcements or reminders. This is a Zoom webinar, so everyone will be muted except for our speakers, but your questions are why we're here. So please use the chat function to submit your questions as you think of them, and we'll get to as many questions as we can in the time allotted. The questions that we don't get to, we'll use for articles in the DMRF magazine, the Dystonia Dialogue, and will help us to develop other resources. So a number of you have submitted questions already, which is great. So thank you for that. If you're not getting the dialogue, please let us know. We want to make sure that that you get it. It's a wonderful resource. So please let us know. Also tonight we are featuring closed captioning. We had a request from a member of the community, and I want to thank her for that request. And so you'll notice that there is closed captioning on your screen. You can turn it off if you'd like. You see this side here at the lower bottom part of your Zoom screen, and you just click on that CC and it'll turn it off for you. But otherwise, we're really pleased to be able to offer that function. So thank you again for that. So now on to our program. We have wonderful speakers for our program. Dr. John McGuire is an associate professor in the Department of Physical Medicine and Rehabilitation at the Medical College of Wisconsin in Milwaukee. He is a practicing physical medicine and rehabilitation specialist at Froedtert Hospital. He completed a fellowship in stroke rehabilitation at the Rehab Institute of Chicago, now known as the Shirley Ryan Ability Lab. Dr. McGuire has led numerous academic and industry studies in stroke and cerebral palsy and related conditions, with an emphasis on therapeutics, including botulinum neurotoxins. He was recently featured in the Dystonia Dialogue to discuss the role of physical medicine and rehabilitation specialists in treating dystonia. Dr. McGuire is board certified in electrodiagnostic medicine and physical medicine and rehabilitation. So welcome, Dr. McGuire. Dr. Bhooma Aravamuthan, sorry about that, is an assistant professor in the Division of Pediatric Neurology in the Department of Neurology at Washington University School of Medicine in St. Louis. She practices pediatric neurology at St. Louis Children's Hospital and Barnes Jewish Hospital. Dr. Aravamuthan completed her child neurology and movement disorders fellowship training at Boston's Children's Hospital and Harvard Medical School. The research in her lab is really patient-focused studies to better diagnose, predict, and understand the causes of dystonia in cerebral palsy. She's led numerous published studies on the pathophysiology of dystonia and CP, as well as diagnosis and treatment. She is board certified in neurology and psychiatry. And last but not least is Hannah Thompson. Hannah is a motivational speaker and program director at Anabaptist Disabilities Network. In high school, Hannah began advocating for those students with special needs, and her advocacy has continued to this day. Hannah is a devoted dystonia advocate and also a disability awareness advocate. Hannah graduated from Elmhurst College with a bachelor's in communications, and in 2020, she obtained her master's degree in social justice from Loyola University in Chicago. Congratulations, Hannah. Hannah served on the Federal Communication Commission's Disability Advisory Committee. She has a blog that we'll put up in the chat, and I encourage everybody to take a look at it and really treat yourself. It's remarkable. I'm really, really proud to say Hannah served as a summer intern here at the DMRF, working on advocacy issues and other projects. And her family, along with Hannah, have held a number of really successful fundraisers to raise support for dystonia research. Our program is really designed to be conversational, and we need your questions to be a part of that conversation. So again, as a reminder, put your conversations in the chat and we'll get to as many questions as we can. So now we're going to have a recorded remarks from Hannah Thompson. Hannah?
Hi, I am Hannah Thompson. I was diagnosed with dystonia at 7 years old due to a brain injury that occurred at birth. The initial brain injury caused cerebral palsy. 7 years later, we saw the onset of dystonia. I have generalized dystonia. This disorder impacts my whole body. Despite these roadblocks, I have chosen to thrive. I have gotten my undergraduate degree in communication at Elmhurst University and my master's in social justice at Loyola University Chicago. I have amazing friends, a blossoming motivational speaking career, and a full, rich life. The role of cerebral palsy and dystonia have played small parts in my life. My diagnosis shapes how much assistance I need throughout the day. However, my diagnosis is not the reason I am a positive person, an organizational freak, a coffee lover, a good friend, and all my identities that really matter. Due to the dystonia as well as the cerebral palsy, I had to go to physical therapy twice a week to undo what the dystonia does on a daily basis. I have a lot of tone throughout my body and my back likes to extend. All of that movement causes pain. Physical therapy consists of pain management and strengthening and balance work. My core strength can get me back to center when my body has large movements. The dystonia is going to do what it is going to do, but with therapy, I can find my center and get back to my life. Besides for therapy, when someone new comes into my life, the movements during that first conversation can lead to discomfort for the new person, but everyone in my life gets used to the dystonia and focuses on who I am as a person, which is so much more important than any diagnosis. One of the questions that the DMRF asked me to address is, what would you say to your teenage self? I would say that life gets so much better after high school. Middle school and high school can be the worst years of your life. Everyone cares about their appearance in high school. They probably don't want to associate themselves with someone who is considered different. In college, everyone is looking to connect. I know in college, nobody cared that I was disabled. I have a ton of friends. We still get together. My life is really full and beautiful. To sum up, I would say my dystonia is secondary. I am so much more than any medical diagnosis I will ever have. My advice for anyone is to be positive and live every day. Get outside, get to know your community, walk, or roll around the world with a happy heart. Thank you for letting me tell a little bit of my story today. I'm honored to be a part of this webinar, and thank you to the Dystonia Medical Research Foundation for what they do every day.
Well, that is a hard act to follow. I had the very, as I said, the real pleasure of working with Hannah when she was a summer intern here. She is a remarkable person, and I'm so pleased that she is a part of this program. So thank you, Hannah, for those remarks. I know all of us can relate to the fact that middle school and high school years are the worst part of our lives. So thank you for reminding us of that as well. I am going to be very casual in presenting questions to our experts tonight, and they have kindly allowed me to call them by their first names because McGuire is so difficult to pronounce. I just don't want to slaughter it. So thank you both. We don't typically do that, but I appreciate that because I want to be respectful of the name pronunciation for everybody. So I'm going to start with you, Bhooma. Would you mind giving us an overview of what cerebral palsy is, and just touch on what is the relationship between CP and dystonia?
Absolutely. And what a great lead in with Hannah's comments. I wish she could talk to my teenage self too. So cerebral palsy is a clinical diagnosis. It's a non-progressive motor disability due to a disturbance in the developing fetal or infant brain. So what that means is it's any sort of motor disability that in and of itself should not get progressively worse with time, that starts very early in life due to something that happens in the developing brain. So that's very broad, right? And that means that there's a lot of differences in different people that have CP. And dystonia in CP is very common. And I'm sure everybody on this call has an idea of what dystonia is, but dystonia is formally defined as voluntary movement triggered overflow activation. So what does that mean? That means every time you try to make a movement, parts of your body that you don't intend to move against your will. And just saying that, you can see how functionally limiting dystonia can be. In CP, dystonia is the predominant motor issue in about 15% of people with CP. But if you look across all people with CP as to how much dystonia they have, not just the predominant form of motor issue, but do they have any dystonia at all? That number skyrockets to between 70 to 80% of people with CP. Wow. So it's extremely common in CP. And it's under-recognized in CP because a lot of people with CP, most people have spasticity, which is another form of high tone. And when dystonia and spasticity are in the same person, it can be difficult to differentiate what part of high tone is spasticity and what part is dystonia. So increasing awareness for everybody in attendance today, for people affected by CP, is important, for their families is important, but it's also really important to increase practitioner awareness of dystonia and CP and work together to make sure that we're diagnosing dystonia appropriately so that we can get people the treatments they need.
Yeah, I think that's starting to happen because part of the motivation for us in hosting this program is that we're starting to see an increase in the number of inquiries from people who have cerebral palsy, who are dealing with their dystonia, and the dystonia is sort of the chief complaint on their daily activities. So I think we may be making some progress with that. John, what's the difference? How would you explain the difference between dystonia and spasticity?
That is a great question. And Bhooma first of all, I want to thank Hannah for being on here too, because that is a tough act to follow. And yes. I appreciate you starting out with her, because that sort of really sets the stage for to answer that question. And I mean, spasticity in and of itself is essentially a stretch reflex phenomenon. And so that is essentially the stretch reflex coming on sooner and stronger than it should. Dystonia, as Bhooma pointed out or mentioned, is a motor overflow. And so where you get muscle overactivity. And so what you see in patients, typically pure spasticity, you're going to see more in people with spinal cord injury or MS, that sort of thing. With cerebral palsy or brain injury or stroke, you're going to see more combinations of spasticity and dystonia, or as Denny Brown described in the 60s, spastic dystonia, which is a combination of spasticity and dystonia. And so the best definition that I like was by Nat Mayer, who talked about anytime you have any damage to the brain or spinal cord, whether it's from cerebral palsy or from stroke or from brain injury or spinal cord injury, Anytime you have any damage to any area, you're going to get a complex mixture of obligatory and compensatory motor behaviors that are difficult to interpret. How do you like that?
That's difficult to say.
And so you get these, and so you get this blur. And so I love the pediatric board came up with a nice model. They, you know, a group of experts in Bhooma, maybe you were part of this, but they had a group of experts, and of course they couldn't really come to much agreement, but they did come to agreement on the fact that there was one category of spasticity, one category of dystonia, and one category of rigidity. And so they have these overlapping circles, and in the middle is kind of where, you know, you sort of get these mixtures of, like I said, these motor behaviors that sometimes are blurred. And it'd be nice if everyone fit into nice one little package, you know, that it was just a clear cut sort of one treatment takes care of all of your problems. You're good to go. Take this pill, take this shot, do this stretch, and you're good to go. But unfortunately, we look at complementary treatments. You know, there's many treatments that need to kind of go into managing patients after any sort of injury to the brain or spinal cord, that it's not a simple procedure. And I wish it was simple and straightforward, and the margins do get blurred, and the definitions get blurred over time. But the bottom line is anytime you have damage to the brain, spinal cord, you're going to get one bucket that includes a bucket of overactive muscles, which includes spasticity, dystonia, spastic co-contraction, abnormal reflex activity. So you get this overactive bucket where the muscles are being overactive. You get this underactive bucket where you have weakness and fatigue. And then you get this third bucket, which is sort of, we call rheologic, or sort of muscle contracture, where if you don't move or if you sit around all day, your muscles will shorten, your tendons shorten, you get contracture. And so there's three major buckets. Anytime I'm looking at patients and you say there's, and you have to manage each of these buckets. You have to manage the overactive bucket, you have to manage the underactive bucket, and you have to manage this bucket that it's sort of like of contractures and that sort of thing. And we do and I always look at that as sort of being a rehab failure when you start to develop this. But, and especially like in cerebral palsy in the kids, you know, where there's this growth and development, and Bhooma, I mean, is going to get into that, but it's sort of, you really have to be mindful of these stages as you grow. And I love your, you know, when you say that CP is non-progressive, you know, I'm coming at this from the adult world. I'm a stroke guy, you know, and an EMG guy. And I kind of fell into, I'm a spasticity guy, but you can't do that without doing dystonia, because it's in the overactive muscle bucket. And so,
so it's complicated.
You know, okay, it's complicated.
It's complicated. And I think that,
I don't want to think
that, but no, I think that's part of what Bhooma, you're talking about, where it's hard to sort of parse this out. And I think from a patient's perspective, and certainly if it's parents, you know, it's also difficult to understand, you know, all of that. And I think, you know, again, from the patient perspective, trying to work with to partner with their doctors to make sure that, as John, you said, you're trying to manage all of these different buckets, treat them, you know, to help the patient. So, Bhooma, are there different types of CP? I mean, you said it's not progressive. I guess I'm a little surprised to hear that. So
yeah,
can you talk a little bit about that, and then are there different forms or different types?
Yeah, there are. So CP tends to be divided up by your predominant motor issue. So you say some people have spastic CP, some people have dystonic CP, etc. And the question of progression in CP, and I see that comment in the Q&A as well, is just such a great question. So progression in CP, the idea of a non-progressive phenotype has really been defined as non-progressive during childhood. But what we know in people with CP as they age is that they tend often to lose gross motor function. So we see in people with CP across the board that their peak mobility tends to be in their teens, and that peak mobility can decline over time. So most of the people today that are alive with CP are adults with CP. So we're learning more and more now about what it means to be an adult with CP and what progressive or non-progressive truly means in the context of the lifespan, in the context of aging. So a physical medicine rehabilitation specialist named Ed Hurwitz, who does a lot of work with adults with CP, says life is a progressive condition. So there's no such thing as a non-progressive condition. And what we tend to see in people with CP is kind of a phenomenon of early aging, where that loss of gross motor function that you might see happen, 60, 70 years down the line, for some people tends to happen in their 30s. The question about progression in the Q&A also mentioned the idea of developing secondary dystonia later in life after having mild CP for many years. Now, that is a phenomenon that is really undercharacterized, because what happens usually for people with CP is there are kind of dystonia nerds, neurologists that follow them during childhood. And there aren't a lot of neurologists or people who are dystonia nerds focusing on characterizing dystonia in adults with CP. So we have heard this message posted in the Q&A over and over again, anecdotally, that people will say, I never had dystonia for my whole childhood. And then in adulthood, I developed dystonia. And it is an ongoing effort on our part as clinicians and as scientists to characterize that in a formal way, to say, hey, this is something we need to watch out for as people with CP age. And it's one of the huge efforts that I'm involved in. We published a paper in Annals of Neurology last year, really kind of begging adult neurologists to pay attention to adults with CP, because there are ongoing neurologic concerns that really need to be managed and treated and screened for, that we really need to work on.
Right. And it sounds like there might be a role, obviously, for a collaboration with physical medicine rehabilitation. Because, John, you're seeing many adults with CP and their dystonia, correct?
Well, yeah. I mean,
and how do you treat it? I mean,
well,
how do you, what do you?
First of all, we treat it the same way. And as Bhooma pointed out, I mean, we're all getting, unfortunately, in the pediatric world, you're getting progressive, you're growing. So this growth and development is you progressively are hopefully getting better, till about the age of 20. But then at the age of 20, we start to get progressively worse. I hate to be the bearer of bad news, but we're all going downhill. And so, and you want your slope to look like this. You don't want your slope to look like this.
Yeah.
And unfortunately, when you have injury early on in age, your slope is already a little steeper. And we all get stiffer, weaker, and lose our balance as we get older. And so unless you do something to mitigate that, like regular exercise, your slope will be steeper. And unfortunately, most people don't do it. Now, it's hard for someone in a wheelchair to just jump on a treadmill and start running, So you have to, and that's what we do in rehab. We look at sort of the world of can do versus can't do. I mean, what can you do to strengthen muscles, to stretch muscles? And that's why therapy, as Hannah pointed out, is so important. And you need to have a skilled person to sort of help direct you through that. But regular exercise, regular therapy is by far the best medicine in the world, regardless of whether or not you have dystonia, whatever ails you in life. Regular exercise is by far the best medicine in the world. And yet 80% of the people don't do it. And so, yes. I get many, I can tell you, I got a room full of progressive CP patients. And I go, no, it's not the CP that's progressing. It's the fact that we're all progressively getting worse. Unfortunately, as you get weaker, some of these things like spasticity, dystonia start to unmask themselves and become more of a problem.
Yeah.
And because you don't have the strength or anything else to sort of combat it, because you fought the good fight for 30, 40 years. And now all of a sudden you're starting to get adult problems, because we have adults with cervical myelopathy. We have adults with, you get adult problems all of a sudden when you get to be 40, 50 years old.
Sure.
And so I have, a very large adult CP population, and they're wonderful. And we keep trying to figure out, and that's that same old thing. You use duct tape, you use whatever you can to sort of say, look, let's look at the world of can do versus can't do, and let's figure out what you can do. Let's, we have some treatments where we can get rid of the overactive bucket, but it's that underactive bucket that's really tricky.
Yeah. So what are the treatments then for that overactive bucket? What is it treated the same way as other dystonias? Are there oral meds that are used with people who have adults who have CP and also dystonia? Botulinum neurotoxins? I mean, is that sort of the treatment that you go to, the treatment menu?
Right. So the oral medications, for generalized spasticity, or generalized dystonia, you're definitely going to need to rely on oral medications or intrathecal medications. There's now, some patients have benefited from DBS. We don't do a lot of that here. For dystonia per se, we do it a lot for Parkinson's. But, you say, well, intrathecal medications or oral medications, you realize, the intrathecal or DBS are more invasive, obviously, but oral medications, the therapeutic window is really pretty small. Where too much, you can cause side effects, too little, you don't get any benefit. Injections work great if you can identify a few, local, it's a focal treatment, so you can't inject every muscle.
Right.
And so, but if you can find a few areas where they benefit, so it works very well if you can if there's certain areas that are triggers, but you can't inject everything. And so, but usually you can calm things down. So we use a combination of treatments. Usually you're optimizing the oral medication, make sure they're not over medicated or under medicated.
Yeah.
Make sure that, if there's a role for injections, that we're injecting the proper areas. It usually works better for neck and arms, because those are smaller muscles. And then we look at, are they a candidate for intrathecal medication or something more invasive, like a DBS thing down the road? But you look at that and you say, well, it's sort of a tiered sort of thing. You do the least invasive thing first, and then you look at underlying causes. Is there anything else that's triggering the movements that make it worse?
Yeah.
Because any irritant can make their dystonia or spasticity worse. And so you look at that. Is there, a bad knee, a bad hip, a bad back, a bad neck? You look at that. But anyway.
And Bhooma, how are you treating it in kids? Like Hannah talked about her dystonia presenting when she was 7.
Yeah.
So are we taking, this is the age-old dilemma in medicine, right? Taking adult treatments and just scaling them down for kids. Is that what we're doing?
So a lot of the treatments that we use for kids, I don't know that I would say scaling them down, but we do have a lot of some emerging data on treatments that are specifically useful for kids with dystonia and CP. There was a beautiful paper published on this just last year, a systematic review of all of this data. Clonidine was one of the medications that kind of came to the forefront for treating dystonia in kids with CP. Gabapentin, there's evidence for that. Both of those medications are really great. It's because of side effect profile and also because of the other things they're good for. So dystonia, like John was mentioning, can be triggered by a lot of different things. So poor sleep can make your dystonia worse. Pain can make your dystonia worse. And if you have clonidine to help your sleep and help your dystonia, for example, if you have poor sleep and dystonia, that can be a good med for that. If you have a lot of pain and pain associated with your dystonia, gabapentin can be helpful for that. Mm-hmm. So those medications are being used more and more in kids with CP and dystonia. Artane is trihexyphenidyl is an age-old medication that's been used for dystonia. The data for Artane is a little bit conflicted and the side effect profile is significant. So we do try to avoid it unless necessary in terms of dystonia treatment in kids. And I'm sure the same applies for adults.
Yeah.
A medication in that class, you worry about a lot of gut and cognitive side effects.
Yeah.
And then tetrabenazine and medications in that class we can also use for dystonia. And depending on the patient, those can be very effective.
Yeah, we actually had a question on that about just somebody asking about the use of tetrabenazine and being worried about depression.
Yeah. So that's a really important concern. And I think making sure that you screen for depression and that you're talking to your practitioner about those concerns are really important. That person also mentioned that they were doing really well on Artane. So I think or on trihexyphenidyl, sorry, I'll make sure to use generics. The thing that is really important, I think, in treating any sort of movement condition, but dystonia and CP in particular, is that there's a lot of stuff you can do to someone. You can put someone on a ton of medications, make them go through a ton of stuff, but I think it's really important to establish what your treatment goals are before starting the treatment. So just making sure that for that person, if they feel like their functional goals have been achieved on their current medication regimen, and they have some dystonia left over, but it's not functionally limiting them, then they're not obligated to add on a medication. The goal is not zero dystonia. The goal is the function that you need.
Right.
So I think being honest about what your goals are can really be helpful to avoid over medicating and adding on treatments that you're a little bit nervous about. If you've met your functional goals, you don't need any.
It's managing those buckets that John talked about earlier, right? And it's just,
and just the last thing I would add here is, again, like John said about triggers for dystonia. So anxiety, stress can be a big trigger for dystonia. And a lot of our kids with CP and adults with CP have anxiety, just like we all do. And sometimes treating that anxiety can help decrease the dystonia. So there are kids with a lot of anxiety where their anxiety triggers the dystonia, where an SSRI, an anxiety-specific medication, can be helpful for decreasing their dystonia because it helps manage the triggers. So identifying the triggers, establishing your functional goals before starting a treatment can be really helpful in terms of tailoring.
Yeah, that's a really interesting comment. We have, as an organization, have been trying to really elevate the conversation around mental health along with the movement disorder so that members of the community address those anxiety issues, and if it's depression, with their doctor, and have an open conversation with them, so that we're treating those non-motor symptoms of this movement disorder as well. So John, you were talking about the importance of exercise, and we've had a couple of questions. One is from one person, and triggers, that exercise actually triggers their dystonia. Certain movements we know trigger certain dystonias. And then, so what would you advise that person? And then, is there general advice about what exercises are good for people? That's a tough question, sorry.
It's very delicate that's why it has to be really tailored to the individual.
Yeah.
And see, now probably by far and away the best therapy in the world is aquatic therapy. Most people don't have access to a pool, but it's a way that you can be unweighted, and usually it's a warm, like a warm water pool can help relax the muscles, and you can actually move better in water. And there are certain centers or certain areas that are really if you go to Europe, or even like when I was actually in Malaysia doing it's different. Aquatic therapy is probably one of the best therapies that you can do. And so for any sort of I love it for any dystonia, any movement disorder, that now, because we can't send people up to the space station because it's a way to be unweighted, because if you can be unweighted, you can move better and that sort of thing. Because that's sort of the tricky part, because you say, well, and then you have to very carefully look at, well, what exactly are you doing? So you need to go to a therapist that really knows what they're doing. It's like a good mechanic, and say, well, what are the real triggers? Because some of them just kind of put you through the usual motions, and you would say, well, that triggers this muscle. And if you can figure out, and it's tricky, it's not simple. You have to really take your time to sort of dissect the problem and say, how are things moving? And is this triggering that, or is it coming from here, coming from there? Is it some low back muscle? Is it some pelvic muscle? Is it some shoulder muscle, some neck muscle? Is there something you're doing that's triggering it? And usually the patient can know that, and they'll say, well, if I do this or do that, well, then obviously don't do that. So you have to figure out, well, what can you do?
Right.
And let's start doing something that basically, and a lot of times it's if you're weighted in the wrong way. So you'd say, well, if it's an exercise bike, or if it's something you can do to unweight yourself and get you in a position that you can start at least doing some sort of strengthening, some, isometric type things, or, that sort of thing. But there's ways of even if you are laying in bed, for God's sake, which you should never do anyway, but there's things you can do to get stronger. And so, but you have to look at the three big buckets of any exercise program, need to include all three of these. And you need to look some sort of strengthening, some sort of resistance training, some sort of stretching component, some sort of balance component, and some sort of conditioning, some sort of, endurance component. Now, you look at all that. Now you'd say, well, if ambulation, or you're not a walker, or you're in a chair all the time, but there's still things you can do for, to get to be strong, or to keep, to maintain some sort of tone and exercise endurance. And so it's really kind of working with the therapist and your physician to kind of figure out what you can do. And if there are certain triggers, because I get this, believe me, I hear this every day in clinic. Oh, I can't exercise because every time I exercise, I get worse. Well, let's take a step back, dude. Let's look back. What exactly are you doing? Well, if you jump on the treadmill, that's not the good. Let's find a different. There's other exercise.
Yeah.
And so you have to strategize and see, because there's something you can do, whether it's exercise bands, whether it's, like I said, bikes, whether it's swimming, there's something you can do to actually strengthen, stretch, and work on balance things.
And so finding a physical therapist is somebody who knows dystonia and knows and CP can really be helpful in this process, right?
Without a doubt. Yeah. Someone there's a neuro rehab, someone that's neuro rehab trained. And, a lot of it, of course, you got the pediatric therapist, you got the adult therapist. Sure. And like as you say, that we've got this huge, literally the huge, everyone's living longer, which is great. And, right. You always think of CP as being kids, but I have a huge adult CP population, and they're wonderful. And we look at this and God, and God love all of them, because the ones that can identify a program, and usually they're working with a trainer that knows what they're doing, sure. Someone that can identify sort of the things you can do versus the things you can't do. Right. Rather than just handing you a book of exercises and say, do this, let's sit down and say, well, let's look at all the things you can do. Rather than let's, forcing you to do all these things you can't do that are going to probably hurt you or make things worse. Right,
and make you feel better about doing them too.
Oh, so, truly, yeah. So there's a window. There's a window for everybody. You just have to figure it out. Yeah.
Bhooma, what advice do you offer parents who are trying to, sort of figure out, they're dealing with their child's diagnosis of CP, and now this dystonia starts to present, and the child may be dealing with some pain issues. So what advice do you offer them on what they should expect, and how their child might be treated during this, especially around the pain, because no parent wants to see their child in pain.
Absolutely.
And then general advice for that family in explaining cerebral palsy to others who just don't have a clue.
Yeah, great question. So having a diagnosis of cerebral palsy, I've found is actually almost like a gate opener for a lot of families. I think when you say cerebral palsy in the community, most people have an idea of what that means, which is, I think, valuable in a lot of ways. So the schools generally have an idea of what cerebral palsy means. So in terms of getting the services you need in schools, therapies, and individualized education plan, often having that diagnosis is like a checkbox for you to be able to proceed with what you need. Insurance companies, it's valuable to have that diagnosis. And I've had families tell me, having that cerebral palsy label has made it easier actually to explain to other families what their child has. Because I think a lot of people have an understanding of, okay, cerebral palsy means that your kid has trouble moving, and that it's not contagious, that, that I don't have to worry about my kid playing with your kid. And that sort of knowledge of CP seems to be ingrained in the public sphere. So I found that diagnosis is often it alleviates a lot of burden on families, actually, and the person who's affected by CP. Explaining dystonia. So I think of almost all kids with CP have some form of high tone, and it's almost always spasticity or dystonia. So I think about explaining dystonia to families as you have one type of tone that's kind of there all the time. So if your kids, toes are pointed, they walk on their toes, they point their toes when they're seated. When they're asleep, maybe they're a little bit looser, but their toes are still pointed. That kind of tone that's there all the time, that's your child's spasticity. That's spasticity. Dystonia is very variable and can look very different depending on how the emotion your child is experiencing. If they're really happy, you might see a lot of increased tightness. If they are shocked, you might see a lot of increased tightness. If they're trying to move, you might see tightness depending on the muscles they're trying to move. And that sort of tone that comes and goes, that's triggered by mood, by movement, and that sort of tone that's not there when they're totally asleep, that's dystonia. That variability of tone is dystonia. So you can look at your child and you can look at yourself as someone with CP and say, okay, I have some tone that's there all the time. no matter what I do or no matter what I'm feeling. And maybe it's a little bit better or worse depending on the day, but it's kind of always there. And I have this other type of tone that's really fluctuating, looks really different depending on what I'm doing, looks really different day to day, very much triggered. That tone ends up being dystonia. So knowing that that kind of differentiation of tone within yourself or within your child can be really empowering to say, you know, that baclofen that you started, or, you know, the turning up the dial on that intrathecal baclofen pump was really helpful for the tone that's there all the time. But the tone that comes and goes, that tone's still sticking around. So what can we do to help that tone? And I think that can be a really useful discussion to have in clinic, and to even have with other people that have CP too, to talk about these tone differences.
Yeah, that's good. We have a couple of questions from people about pediatric use of botulinum neurotoxins. So how young is too young to start botulinum neurotoxin therapy? And then we could hand it over, John, to you. Questions about the long-term use of botulinum neurotoxins in adults. We've had a couple of questions from people just saying, you know, if I've been on this for 20 years, is it safe for, you know? So Bhooma, why don't you start with the pediatric use, sure, and then John will ask you to comment on the long-term use.
Yeah, this is a topic of intense controversy in the field, actually, in terms of how the longitudinal effects of Botox. So botulinum toxin, we use it when it is helpful to achieve a functional goal. So, and that's kind of how we frame all of our treatments for our folks with CP. So if your functional goal involves being able to walk without pain, and your orthotics and PT and stretching and your overnight stretching splints are just not cutting it, giving you the range of motion you need, then we'll pursue botulinum toxin for those calf muscles to help loosen them up. We've done botulinum toxin in very young babies with generalized dystonia, a year of age even, when the dystonia that they have is so tight that it's very difficult to clean under their arms, and they have breakdown because their dystonia is keeping their arms locked so tight. Or it's difficult to change them because whenever you try to change them, they end up locking their legs.
Yeah.
And so Botox can be helpful in those situations too, when it's targeted to achieve a functional goal. Do we go to Botox as the first medication we do? No. And is it helpful to do Botox in a sparing way, just like all medications? It's helpful to do it with regards to achieving a functional goal? Yes. There is a lot of data, primarily from animal models, that shows that repeated high-dose Botox in healthy animal muscle can reduce the volume of that animal muscle and cause muscle issues. But it's very difficult to generalize that dosing in a healthy rabbit to what's happening in a person with CP who has very tight overactive muscles that really are abnormal at baseline. How do we loosen up those muscles? So the question is an ongoing one. I think Botox, like any medication, should be used sparingly and to achieve a specific functional goal that you set up front.
Yeah, thank you. John, what about long-term use in adults? What do we know about its safety, botulinum neurotoxins, to help that dystonia?
Sorry about that. My pointer thing all of a sudden went dead. So anyway, that was Bhooma, that was great. So the deal is yeah, when you have to be careful when you compare animal studies to human studies and over time. Because it's really any medicine, and this is true, the difference between something being, you know, therapeutic and toxic is really dose, right? So if you put a large dose in any muscle over a long period of time, yes, that could be detrimental to the muscle, but that's not really what we're doing. You know, we're looking at, and you're right on target here. It's all about functional, goals. What are you really trying to accomplish by relaxing a muscle? And so the toxins, and fortunately now we have, like 4 commercially available toxins now that we can use. And for some people, Botox works better. For some people, Dysport works better. For some people, ZM works better. For some people, Myoblog works better. So we've got different toxins to use, and there's probably 200 uses for the toxin. And when you get to in the adult world, in the pediatric world, you look at there's in the adult world, all of a sudden people are doing their wrinkles all of a sudden. People are doing things for hyperhidrosis, things they're doing for bladder management, for overactive bladder. But the huge area that it's really sort of evolved in is the whole area of pain management. And we know that it's approved for headaches and chronic migraines and chronic daily headaches, but that soon to be, they get approval for neuropathic conditions like trigeminal neuralgia and that sort of thing. And so we know that spasticity or dystonia, tight muscles can be painful. And so as always, we thought, well, we're just injecting this stuff, we're relaxing the muscle, and that's why their pain goes away, or hopefully goes away, or can be reduced. And it does, and it actually works wonderfully for that. But I think the other issue it does, and the toxins do 3 things. I mean, they relax the muscle itself, but it also relaxes spindle information. Your muscles have spindles, which are stretch transducers, and that probably has a big role in dystonia and spasticity. And then it also blocks pain fibers. Your pain fibers, we thought that all the pain benefit was relaxing a muscle, but now we realize it's really blocking your pain fibers. Your pain fibers release substance P and glutamate and these neuropeptides that the toxins block. And so you're actually doing 3 things when you do these injections. So I would say 40% of what I'm doing now is actually pain related, or there's a pain component. And that's why things like, as Bhooma mentioned before, when you treat oral medications, you look at, the pain component, which is sort of underserved and under-recognized, but that's why gabapentin is wonderful. And in the adult world, I'm looking at, I call it my brand, in here in Wisconsin, brandy's a big thing, but brandy old fashions, and I call it my brandy old fashioned for spasticity, man. Now you can't do this for kids, or maybe, but you look at, and I use it. You shouldn't do it, but it's a combination of low doses of different medication work better than high doses of multiple medication. And so I look at a little baclofen, a little tizanidine, a little gabapentin at night. I tell you, you sleep like a baby, and you wake up feeling, if you can get a good night's sleep and you aren't as tight and not as much pain, it really goes a long way to manage these pain. And so you have to look at this combination of, again, it's titrating all these medications. Yeah. But I've injected people. I've been doing this ever since it started. So I've been doing this a long time. And I've injected people for over 20 years. It still works. Yes, if you put a huge dose in a small muscle, you can get atrophy, you can get shortening of muscle, but you have to look at, well, what is their overall benefit? And unfortunately, you see this a lot in the cosmetic world, that people want. But look at their faces. Their faces look awful. And so you say, well, you've overdone it, and that's because you can overdo it with the drug, like any drug. If you overdo it, then you can get problems. But if you do it for the right reason, if you do it for the right reason at the right time and the right dose, it can all be done safely for a long period of time. You're using very small doses of this medication, using nanograms of the drug. And so if you think about it, if you do it in the right way for the right reason, but if you put huge doses in a small muscle, yes, you're going to get problems.
Yeah. What about long-term use of intrathecal baclofen on a pump? Is any studies to show that that's fine? We've had a couple of questions about that.
Yes, it's been well tolerated. The devices, the catheters were used the issue over time, as far as, but the catheters have gotten a lot better. The pumps have gotten a lot better, really. They've made improvements with that. Anytime you have an implantable device over time, there's a risk of issues. But for the most part, it's probably the best way to get rid of bad stuff and keep good stuff. And it's been extremely well tolerated. It's a great drug delivery system. The best way to deliver, rather than taking it orally when the drug goes everywhere, this way you can deliver the medication right to the source. Issues in the pain world where they start to mix other drugs in there, that's where you might get issues, more complications with other drugs that can cause granulomas and things like that. But for the most part, with baclofen, you know, the stories about it, you know, tolerance and that sort of thing, it usually turns out that there's some issue with the catheter or something like that.
Yeah.
And so when you fix it, for the most part, there's been, I've had more issues with clonidine as far as long-term tolerance, or morphine long-term tolerance. Baclofen tends to be pretty well tolerated over time, for the most part.
Yeah.
And so I don't see a lot of, you know, people having trouble with that. So it can be a long-term, you know, it can be a short-term or long-term, you know, issue. You can always take the thing out, you know, and so, you know, that's, you know, it's not a, you'd be able to put it in and go, well, if it's not working. So for our population, we've only taken out a handful because we couldn't get it adjusted to their liking. And so for the most part, we can titrate the dose to where they, to their satisfaction. And so, but you can always take it out if it's not working. But for the most part, pretty much, and my gold standard is always like, if there's a problem, most people want it back in because they always say nothing worked better than the pump.
Yeah, yeah. And Bhooma, how young can baclofen be used, both orally and as a pump?
We do baclofen orally out of the NICU, out of the neonatal intensive care unit. So we use orally, we can do it at a very young age. Surgically, that depends on some factors. Largely, it depends on weight and your ability to tolerate having hardware in your back. So it's not necessarily a strict age cutoff. It's more of a weight and how much muscle and fat do you have on your body to be able to tolerate having a pump on your body sort of cutoff. So, and that takes time. So that's, you know, 7, 8, that sort of age that we start thinking about baclofen pumps. If at all, if that early.
Right. So we typically get this question about the use of medical marijuana, you know, for dystonia. You know, I think it presents some additional challenges when parents are trying to consider the use of CBD with their kids. So again, like we did with the botulinum neurotoxin, Bhooma, would you comment on this? And then John, if you would comment on the use of medical marijuana in adults, that would be helpful, I think, to our viewers.
Yeah, so I think a lot of our patients have started using CBD in some form or have tried CBD in some form. With the recent approval of the medication form of CBD, of Epidiolex for epilepsies, a lot of our kids with CP have epilepsy and some of them are on Epidiolex. With regards to prescribing a medication like that for dystonia, because there's no data on it, I don't prescribe it for dystonia. But there are, depending on the state, many areas where you can get medical marijuana yourself. And I think that's fine. I mean, there are over-the-counter things you can get. And if you find benefit in it, I think it's totally reasonable to pursue that. I do ask that families talk to me about when they're starting it, because just like anything you put into your body, it has side effects and it has interactions with other medications. So in particular with CBD, clobazam is a medication that we commonly use for seizures and for dystonia. And Epidiolex or CBD can increase the levels of clobazam. So it's just important to keep these things in mind. So if you're interested in starting that medication kind of off-label, just let your practitioner know so they can monitor the levels of the effects on your other medications and monitor for side effects.
Yeah.
I think it's reasonable to pursue, but the data for it is not currently there.
Not there. And I would just add before, John, turn it over to you, that we recommend, obviously, anytime, whether it's, you know, medical marijuana or herbs, you know, you get people who are talking about, they go to an herbalist and they're going to help with their pain or help with their flexibility or whatever, that these are really, you know, they have to be looked at as medications, and you have to have a conversation with your doctor about what you're doing. So that's our general advice too. So John, would you comment on the use of medical marijuana in dystonia in CP adults?
Yes. So I'm in Wisconsin, so it's not legal here at all. And so, you know, we are more concerned, but there's clearly a role for patients that clearly can benefit from it. But it's like any medication. You have to be mindful, like Bhooma said, you have to be mindful of other interaction with other medications, and it's all dose related. The only difference between anything in life between being therapeutic and toxic is dose. Nothing more toxic than too much water. And so you have to look at the marijuana or the THC, you know, and for me, it's unfortunately, if you look at just CBD, most of my patients, and maybe it's different in children, but, you know, most of the adults that I deal with, you know, some are using it and they say nothing works better than that. And they're not drug heads. They're not like pot heads. They're not like this sort of thing. And the issue is that it's a plant. You know, if you get all the pharmaceutical variants of it don't seem to work as good as the natural thing. And it's sort of like a good wine. You know, remember, it's a plant. So some years are better than others, even though you get the same mixture, the same combination from the same person. Still a little bit different, and they'll say this batch was really good or that batch wasn't quite as good, and as long as you don't overdo it, there might be a role for, you know, the right dose, but that's sometimes tricky to titrate, and it's also tricky to, you need to understand how it can interact with other medications. So you're really walking a fine line, but not to say there's not a role for it, and I wouldn't poo-poo it or rule it out by any stretch. I can't recommend it. You know, don't ask, don't tell in this state. You know, I just say, look, you know, if you get a good batch and it's helping, you know, but it's like sometimes, you know, it's not consistent. And I wish we could get a consistent batch that would say, because clearly, you know, the THC you have to worry about, but for some people that component does give them the added benefit, but that also gives you more side effects. And so you have to look at, but there, you know, it's like anything, you know, it's all about dose, and don't overdo it. If you're going to do it, be careful and be mindful of other interactions.
Yeah. Yeah. We are sort of running short on time. We've had amazing questions coming through, so we may have to do a part 2, but I want to
I'm in.
Bhooma, if you
dress up for that. No.
Yeah. Hey,
I was hoping this was going to be a Halloween party.
Let's absolutely. Bhooma, would you talk a little bit about, John referenced that they don't really do a lot of DBS at his place for dystonia, but I know parents are interested in DBS for their CP kids with dystonia. Can you comment on that?
Absolutely, yeah. So this has really come out in the last 5 or 6 years, the idea that DBS can be helpful for some people with secondary dystonia. So dystonia is in the setting of cerebral palsy. There are some centers that are doing it. The center that I'm at, WashU, does do DBS for dystonia in children, including secondary dystonias. The best candidate for DBS is a long conversation. So what we want to see is that the part of the brain that we're targeting with the electrode is still relatively intact. So it's, first we look at the MRI, but beyond that, and I feel like a broken record here, we focus on functional goals. So what is it that you want to achieve with DBS? DBS can be a good option for people with generalized dystonia who have been refractory to, who have not had good responses with different medications, who are really just looking for kind of a general decrease in their overarching dystonia, but are not necessarily expecting all of their dystonia to, kind of magically go away. The data we have on DBS for dystonia suggests that the people with CP feel like they have functional improvement and also improvement in their pain to some degree, but that's not reflected in practitioner scores of dystonia severity. So DBS for dystonia and CP can help, and it has helped. People with CP say it helps them with regards to function and pain. So if you're looking for an overall improvement in function, like I want to be able to sit in my adaptive stroller or adaptive wheelchair a little bit better, dystonia is making me buck out a bit, I have all of these dystonic movements all the time, I'd like to calm that down a little bit because I'm really maxed out on meds, DBS might be an option for you. If you have focal dystonia in one arm and it's responding decently well to Botox, but you're wondering if you can get rid of the Botox by doing DBS, no, DBS is not an option for that.
Yeah.
So focusing on those nuances is important.
Okay, that's helpful. Thank you. We've had numerous questions about CP and speech, CP dystonia and speech. And I think that's probably almost a whole category in and of itself. But I was wondering, John, if you have a recommendation on an affordable form of speech recognition software that might, you know, Hannah obviously very successfully utilizes hers, or Bhooma as well. I mean, if you do, and that's something we can actually also get back to everybody on if you want to think about it a little bit. But you know, speech and CP is an issue, and a number of questions about that. So we'll want to circle back to that for sure. But any quick comments on suggestions or thoughts?
I don't know what things cost, but I will look into it and I can get back to you on that for sure.
Okay, thank you.
Because I know patients, you know, have tried different ones, and I'll ask around and see, you know. But you know, again, what things cost, I should be more aware of that, but unfortunately, I don't know.
No, that's fine. You're both incredibly busy, so I appreciate that you may not know all the details, but thank you for your willingness to help us with that. So. This has been, I can't believe an hour has expired already. This has been really enlightening. I want to thank Hannah for starting us off tonight, and for all of her advocacy that she does on a regular basis. I can tell you, I've been in Washington, I've been in the halls of Congress with Hannah, and she is hard to keep up with. She is a ferocious advocate. So I thank Hannah for that. And I thank you, Bhooma and John, both of you, for your sharing your expertise with us tonight and your insights and your advice. And I think most importantly, for the work that you do every day to help those who have cerebral palsy and dystonia. And you're making their lives better. And we're grateful to both of you for that work. So thank you very much. We look forward to scheduling part 2, because I think there's definitely an audience for that. This has been great. Again, everybody, thank you for your questions. Thank you for tuning in. And until next time, thank you very much.
Thank you,
everybody.
Bye-bye.
Bye.
Have a great night.